Hi, a very good evening, each and every one of you. So today's live session will focus on the following topic. We'll have some select image-based discussion from oral radiology. I hope you guys are all ready. So please excuse me for starting this session a bit late. As I said, I'm out of station and I'm at a different place. And I'm trying to make sure that I have all the connections properly so that we don't have any disturbance during the session. Luckily, everything is going on well till now. So let's hope we can carry on with our session as usual. So how are you guys doing? Please confirm the audio and video quality. If you want me to raise my voice, I can do it accordingly. Yeah, please confirm the audio and video streaming. And simultaneously, I'll be watching you guys here on another screen, and then I'll be evaluating your answers accordingly, right? Yeah, thank you. Thank you so much for all your love and affection. I'm doing good. Actually, I'm out of station. My parents are back at home. Yeah, they're doing good as well. Yeah, thank you. Yeah, fantastic to hear that. So let's start with our presentation now. I hope you guys are all ready. And before I start, I have a request to each and every one of you. Make sure you're going through the information which is being provided carefully and make a note of any relevant point which you find it important. In the process of reviewing literature from White and Farrow in the process of this session or discussion, I'll be highlighting certain points, and feel free to note down any points based on your convenience in your customized notes. And I'm sure you're going to enjoy this session. And most importantly, I'm confident that you're going to answer all these images accurately, right? Yeah, let's proceed with our session. So first and foremost, we can see this is actual picture taken by us while we were in Switzerland. So this exact location, which you can see on screen, it is Ungfra. It's pronounced as J is silent, Ungfra. Ungfra George, Ungfra. So it's considered to be the highest peak in entire Europe with an altitude of more than 4,000 meters. That's very surprising. So Ungfra at a height of 4,158 meters is one of the main summits of Bernese Alps, which is located halfway between Interlaken and Fisch. So these are some towns or places in Switzerland. I would recommend all of you to please visit this place. If not now, at least after December 16th, you can plan a trip. I'm sure you can do that. Good news is you're talking about vaccine by Pfizer, which is effective in more than 90% of the cases. So let's hope for the best. So as you can see, mountains, snow, blue sky, nature as such, again, is very inspiring. Previously, I've shown you an image of green grass and blue sky, sunset. Take any element of nature, it's very, very inspiring. That itself gives you a lot of calm, and it helps you stay composed, isn't it? Okay, so let's proceed with our. It's beautifully captured, thank you, but it has nothing to do with us. As such, nature is very beautiful. So no matter how you capture, it's going to be fantastic, without any doubt. Anyways, thank you for your appreciation. So let's proceed with our discussion. So as a custom, before we move on to oral radiology related questions, we'll start with previous sessions case-based question. Yeah. So this is not Vijayawada. No, that's in Switzerland. The image is not from Vijayawada. Vijayawada is my hometown. Okay, case-based question. So I've asked you this question yesterday before concluding the session. So what's your answer? You're performing ultrasonic scaling and patient complains of sensitivity in relation to lower anterior teeth 3-1 and 4-1. All of the following actions are appropriate to counter this problem, except option A, proceeding to another tooth and then returning to sensitive tooth later in appointment. Option B, moving the instrument slower. Option C, turning up the power of device. Option D, using less pressure. So which of the following options do you think is more appropriate? As I've given you a hint, this question has multiple right options, not single right answer, multiple right answers. So which options would you choose? Yeah, Agalia says B and C. Monica says B and C. Fantastic. So you all belong to before Christ, BC, B and C. How many of you have chosen A and D? None? Oh, it's very unfortunate. But we are in AND, 80. Okay, so both B and C options are right, as you all rightly, as some of you rightly mentioned, because if sensitivity is encountered during using ultrasonic scaling, please make a note of the following. Try to lighten the pressure. Right? Usually when we are scaling, we apply so much of pressure because we think it's calculus and we have to apply so much of pressure. No, not actually required. In fact, in the process of applying pressure, you might abrade the surface. That's possible, and there are many studies proving the same. So if sensitivity is encountered, yes, BC, lighten the pressure, adjust the water spray, that is, increase water flow to cool the tip. Very, very important in clinical. You can consider this as clinical tip. And move to another teeth and return later to sensitive teeth as mentioned in option A. Decrease the power. You can decrease the power. So these are some of the measures which you can take, right, if sensitivity is encountered during ultrasonic scaling. Power-driven instruments, as you all are aware of, as you might have experienced them, these work best with quick hand movement, not slow hand movement. Quick hand movement, rapid, controlled movements. And as you all know, ultrasonic scaling, the ultrasonic principle is based on use of high frequency sound waves, right? So B and C are the exceptions. I hope you got my point, and congratulations to all those who have answered it right, and those who haven't answered it right. Now is an opportunity for you to edit the information, update it, update the status, and then progress accordingly. Okay, now let's move on to our next. Again, the first question of oral radiology quick revision class, image-based question. Before you answer, I haven't given you options intentionally. Instead, I've given you some hints. So observe the image and simultaneously go through the hints as you can see. Identify the following based on the given hints. First hint, it's the most common type of cyst in jaw. I've given you a hint, it's a cyst. So it's one of the most common type of cyst in jaws. There is often or sometimes associated history of trauma, the second hint. And third hint, thought to grow. This cyst is thought to be growing by osmotic pressure. And then final hint, this cyst has slight male predominance. So based on the given hints, based on the radiographic appearance, which one do you think would be the more appropriate answer? Which cyst is this that's being projected right now on your screens? So you can see some arrow marks over there, two black arrow marks. Also you can see well-defined outline, and there seems to be radiolucency inside this cystic space, and it seems to be associated with apices of teeth. So you are getting plenty of hints, plenty of clues. Fantastic. So keep answering. In the meantime, let me review some literature. So radicular cysts are, the moment I say radicular cysts, what's there to answer? You might ask me this question, but please keep answering because active participation is very important. Take my word, active participation is the key. So radicular cysts are the most common type of cyst in jaws, as you can see in the hint that's given over there. These arise from non-vital teeth, right? So non-vital teeth can be because of trauma, can be because of caries, can be because of large restorations, iatrogenic causes, whatever it is. And a radicular cyst is a cyst that most likely results when rests of epithelial cells in the periodontal ligament are stimulated to proliferate and undergo cystic degeneration by inflammatory products from a non-vital tooth or teeth. This cyst is thought to grow by osmotic pressure, and the incidence of radicular cysts is greater in 3rd to 6th decades and shows slight male predilection. So based on this, you have these hints, and let me briefly describe the location and the relevant points in specific to this radiographic appearance. So yeah, radicular cyst, as most of you are answering, it's radicular cyst. So location, in most cases, the epicenter of a radicular cyst is located approximately at the apex of non-vital teeth. It occasionally appears on mesial or distal surface of a tooth root at an opening of accessory canal or infrequently in a deep periodontal pocket. And most radicular cysts, almost 60%, are found in maxilla, especially around incisors and canines. Please make a note of this point. And radicular cysts may also form in relation to non-vital deciduous molar and be positioned buccal to the developing bicuspid. Periphery and shape. The periphery, you can see a well-defined cortical border, which is highlighted by the arrows in the image. And if the cyst becomes secondarily infected, the inflammatory reaction of surrounding bone may result in loss of this cortex or alteration of the cortex into a more sclerotic border. And the outline of radicular cyst usually is curved or circular in this context, unless it is influenced by surrounding structures such as cortical boundaries. And effect on surrounding structures. Let me conclude with this, because any cyst, its effect on surrounding structures, it can be resorption, it can be pressure-related changes that are very, very important. So radicular cyst, if it is large, there can be displacement or resorption of roots of its teeth, which is possible. And the resorption pattern may have a curved outline. In rare cases, the cyst may resorb the roots of a related non-vital tooth. I'm sure you might have seen such cases in your clinical practice or in your colleges. You'll find a radicular cyst and you'll find that the apical third seems to have been resorbed. In such cases, we even alter biomechanical preparation and obturation, right? So that's another important clinical criteria. And the cyst may invaginate into sinus, but there typically is evidence of cortical boundary between the contents of cyst and sinus cavity, and the outer cortical plates of maxilla or mandible may expand in curved or circular shape. So cortical expansion is very much possible. And cysts may displace mandibular alveolar canal in an inferior direction. So some additional inputs for you based on the literature that's available in White and Farrow, right? I hope it's clear. And now, let's move on to our next question. Even if you have answered it wrong, no problem at all, because you always have the opportunity to identify the mistakes, upgrade your information, and then progress accordingly. And this applies not just now, even on the day of exam. So, which means you should have a kind of orientation that even if it's a day of exam, exam is a learning experience as well. Most of us think once we are done with exam, we just tear the question paper. We used to do that previously during childhood. We used to throw away all the papers out of frustration and agony. But no, exams are also an opportunity, right? So let's move on to our next question. Identify the following again based on the given hints. So, as you can see, again, a periapical IOPA, there seems to be impacted tooth, and there seems to be some radiolucency around the impacted tooth, which are highlighted by two white arrows. So what could this be? Obviously, it's a third molar, right? It's a third molar. So identify the following based on the given hints. This is also called as follicular cyst. It's the second most common type of cyst in jaws. Remember, the first most common we discussed previously. So this is the second most common type of cyst in jaws. This is in the context of diagnosis, this third hint is the most important. Please do underline this, or just make a note of it, right? This attaches at CEJ, more or less at cement enamel junction. And the propensity to displace and resorb its teeth is evident with this particular cyst. So which cyst are we talking about? You can see an impacted tooth surrounded by some radiolucency, and that radiolucency seems to be almost ending at the level of CEJ. So what could this cyst be? Okay, fantastic. So let me review some literature in the meantime. Follicular cyst is a synonym for dash cyst. And these dash cysts are the second most common type of cysts in jaws. They develop around the crown of unerupted or supernumerary tooth, and the clinical examination reveals a missing tooth or teeth and possibly a hard swelling occasionally, resulting in facial asymmetry, right? So it is dentigerous cyst, as you rightly mentioned. So dentigerous cyst, let me just mention few points regarding its location and then effect on surrounding structures, and then we'll move on to our next question. Please let me know, do you want me to review this literature, or do you want me to just skip the question? Because in my opinion, it's always good to review some additional information related to the key rather than just sticking on to the key. So what do you guys say? Again, it takes 20 seconds for you to reach this. So in the meantime, let me review some literature and let me know your opinion. Yeah. Okay, so coming to the location of dentigerous cyst, the epicenter of dentigerous cyst is found just above the crown of the involved tooth, most commonly a mandibular or maxillary third molar or a maxillary canine. An important diagnostic point is that this cyst attaches a cemento-enamel junction, the third hint which I have mentioned. Some dentigerous cysts are eccentric, developing from lateral aspect of follicle so that they occupy an area beside the crown instead of above the crown. So there can be alteration in positions, which is very, very important. And cysts related to maxillary third molars often grow into maxillary antrum and may become quite large before they are discovered. And cysts attached to crown of mandibular molars, as in this case, may extend a considerable distance into the ramus, right? Even that's a possibility. Effect on surrounding structures, very, very important again, because this will give you, this information will give you various hints and enables you to answer the question more efficiently. A dentigerous cyst has a propensity to displace and resorb its teeth, one of the hints which I have mentioned here on the screen, and it commonly displaces the associated teeth or tooth in apical direction. Very, very important. And the degree of displacement may be considerable. For instance, maxillary third molars or cuspids may be pushed to the floor of orbit. Mandibular third molars may be moved to the condylar or coronoid regions or inferior cortex of mandible. The floor of maxillary antrum may be displaced as cyst invaginates the antrum, or cyst may displace the inferior alveolar nerve canal in inferior direction. This slow-growing cyst often expands the outer cortical boundary of involved jaw. This point is again very, very important. I mentioned two important points. In diagnostic point of view, this attaches at level of CEJ, and the second most important point is this slow-growing cyst often expands the outer cortical boundary of involved jaw. As in the case of radicular cyst, dentigerous cyst that invaginate the sinus can drain collapse with newborn formation at periphery. You can ignore this point, but make sure that you're highlighting those key points, okay? So as you all rightly mentioned, it is dentigerous cyst, and let me look at your answers. Yeah, please do review. Okay, that's fantastic. I'll go by the majority, obviously. Now, let's move on to our third question, no hints. Just observe the radiographic image, and based on what we have discussed now, what do you think it is? A dentigerous cyst or keratocystic odontogenic tumor? I know it's a challenge, and I'm sure you're going to do it well, extremely well. So which one do you think is more appropriate answer? I've given you two options, choose one. We've discussed about dentigerous cyst now, its probable location, its size, deviations, right? So what do you think this is? Dentigerous cyst or KOT? If you remember, I mentioned about one important point in diagnostic perspective, that is dentigerous cyst attaches almost at the level of CEJ. But look into this radiographic image. Do you think you can find attachment at the level of CEJ or apical to CEJ? Right? It's not at level of CEJ. So it's not dentigerous cyst. But it appears like dentigerous cyst because it is associated with an impacted tooth, and it seems to be at the center. This tooth impacted tooth seems to be at the center of the cyst epicenter. So based on that, you might think it is dentigerous cyst, but it is not. As you all rightly mentioned, exactly. This is KOT, keratocystic odontogenic tumor. Some important points. Before that, when in a pericoronal position, I'm talking about KOT, when in a pericoronal position, as you can see, a KOT may be indistinguishable from a dentigerous cyst. The lesion is likely to be a KOT if the cystic outline is connected to the tooth at the point apical to cemento-enamel junction, or if no expansion of cortical plates has occurred. So no expansion of cortical plates in case of KOT, but in case of DC, I mentioned two important points. Now I think it must be very clear for you, right? So you got the diagnosis. Now, what is KOT? So most common location and all, let me review some information and then we'll move on to the next question. The most common location of KOT is posterior body of mandible. Almost 90% occurs posterior to canines, as you can see in this radiographic image. The epicenter is located superior to inferior alveolar canal, and this type of cyst occasionally has the same pericoronal position and is indistinguishable from dentigerous cyst. Okay? Yeah. Effect on surrounding structures. An important characteristic of KOT is its propensity to grow along the internal aspect of jaws, causing minimal expansion of cortical plates. It's minimal, right? I hope you got my point. And this growth with minimal expansion occurs throughout the body of man, except for upper ramus and carnoid process, where considerable expansion may occur. So we have some exceptions, right? So consider these points relevant, and I hope you got the distinction between dentigerous cyst and KOT. even though both can be considered in differential diagnosis, but we have certain specific points through which we can differentiate both of them. Okay, let me stop this here and then let's move on to our next question. Yeah. Fantastic. Now let's move on to our next question. So you can see a radiograph, premolars, restorations present, and then you can see something like a tennis ball structure, a ball-like structure, a cricket ball or tennis ball-like structure along the lateral aspect on mesial side of the second premolar, right? Yeah. So what do you think it is? So identify the following based on the given hints. This particular lesion is asymptomatic, less than 1 centimeter in diameter, and it mimics a lateral periodontal abscess. I'm sorry for the spelling mistake, it's lateral periodontal abscess. It mimics lateral periodontal abscess if secondarily infected. So what do you think this is? Right? Mental foramen? Mental foramen, that would be even more obvious. That would even be more radiolucent. And I'm sure we can clearly make it out. And do you see any clear, distinct outline or border? Right? Seems to be some cortical border. Yeah, so obviously it's a cyst. And as most of you mentioned, yes, it is lateral periodontal cyst, but if multiple cysts occur, as Kirti mentioned, botroid, okay, fantastic. Now let's review some literature related to the same. So lateral periodontal cysts are thought to arise from epithelial rest in periodontium lateral to tooth root. That's where the location is, as you can see in the illustration. And this condition usually is unicystic, but it may appear as cluster of small cysts, as Kirti mentioned, a condition referred to as botroid odontogenic cysts. One important point. And it has been postulated that a lateral periodontal cyst is the intrabony counterpart of gingival cyst of adult. You can definitely expect a question along these lines, right? And clinical features, I've given you some hints based on that. So usually asymptomatic and less than 1 centimeter in diameter, and no apparent sexual predilection. And if these cysts become secondarily infected, they mimic lateral periodontal abscess. It is lateral periodontal abscess, okay? And location of lateral periodontal cysts, 50 to 75% develop in mandible. You need not worry about the percentages, at least make sure that you have that majority, general phrase in mind, that most of these cysts occur in mandible, and mostly in region extending from lateral incisor to second premolar. Most cysts are small, as you can see in this particular radiograph, but occasionally this cyst can attain a considerable size. And the cysts can also appear in maxilla, especially between lateral incisor and cuspid. Don't worry about these points, okay? Majority of the cysts can be seen in mandible, right? Mostly in the region extending from lateral incisor to second premolar, as evident in this particular radiograph, right? Okay, fantastic. Now let's move on to our next question. I'm sure you're going to answer this with 100% accuracy because you're all youth and you all have heart and you all can show love upon self and others. So consider this as a hint, okay? I don't mean those words. I'm just giving you a hint. Okay, I mean those words. So identify the following based on the given hints. This particular cyst, you can see a radiolucency between central incisors, and you can see a clear cut outline, right? Cortical line. So accounts for 10% of jaw cysts. Incidence is 3 times higher in males because males love more. Males love more. I'm not talking about any other sex. I'm just talking about males, okay? So now don't blame me. So found in Nasopalatine foramen or canal. So which one do you think it is? And why am I talking about heart? I'm sure you know the answer. So Nasopalatine Duct Cyst, right? So a Periphery and Shape, first we'll start with this so that we can understand how it actually looks. Usually it's well defined and corticated as evident in this radiograph. And it is circular or it is oval in shape. Here it seems to be neither circular nor oval, but a heart shape, isn't it? So the shadow of nasopalatal or nasal spine sometimes is superimposed on the cyst. As you can see, it's not so clearly a heart in this particular radiograph, but if nasal spine superimposes on the cyst, it gives a heart shape, right? So now you know what I'm talking about. The second hint, incidence is 3 times higher in males. So nature is telling you something, telling you all something, telling us something, that males have propensity to love more than someone. Okay, so Nasopalatine Duct Cysts, they appear, they account for around 10% of jaw cysts, as you can see, and they are mostly found in Nasopalatine foramen or canal. Most Nasopalatine duct cysts are found in Nasopalatine foramen or canal. However, if the cyst extends posteriorly to involve hard palate, it's referred to as median palatal cyst. And how can you say whether this is non-odontogenic cyst or whether this is a radicular cyst? I mean, you can think of it as a radicular cyst, right? Because it seems to be around the apical portion of the roots, central incisors. So how do you actually differentiate that from a pathology? So carefully observe the root outline. Carefully observe the root outline. You can see normal period space, no disturbance in the continuity in the lamina dura, right? So that's quite obvious, isn't it? Yeah, so uniformity in periodontal membrane space around all epices is a very important point in diagnostic relevance, right? Yeah, vitality of tooth, it means the teeth is vital. Or you can go for vitality. Excellent. Yeah, you can see root apex, you can see normal PDL space. Good, good. Fantastic, fantastic, right? And also make sure, see, these hints also can be considered as relevant, important points, okay? Right. I know I'm going a bit fast in this session, but for this session exclusively, I'll try to revise the entire information in a brief manner at the end of the session for your convenience, right? Now let's move on to the final aspect, case-based question related to oral radiology. Again, please don't answer this question. I want you to find out the answer. Why do you think that one particular option is more appropriate? We can discuss the same in our next live session. Okay, so after developing her bite wings, a female dentist, after developing her bite wings, a dentist realizes that she has too much overlap between the contacts of adjacent teeth. So this is an error caused by option A, too much vertical angulation, as in selfies, too little vertical angulation, that is the moment you open your front cam, you get frightened, we get frightened looking at our own face. Option C, incorrect horizontal angulation. Option D, beam not aimed at center of filling. I'm not going to look at your answers. I'm going to close my eyes. Okay, really appreciate your enthusiasm, but try to find out why a particular option is more appropriate. We'll discuss this tomorrow with some diagrammatic approach. Okay, so before I conclude, I know I've reviewed plenty of information. Let me just go through them in brief. So case-based, we've discussed this already. So option B and C, BC, as you all rightly mentioned. So consider them as clinical tips, right? So whenever patient experiences sensitivity, right, lighten the pressure, adjust the water spray in order to, in an attempt to cool the tip, or you can move another tooth and return later to sensitive tooth distraction and decrease the power. So first question, so identify based on following hints. So it is a case of radicular cyst. So it's one of the most common type of cyst in jaws, non-vital teeth, associated with non-vital teeth. That's a take-home message, right? And it's thought to grow by osmotic pressure and slight male predominance. So radicular cyst it is. And you can see clearly a well-defined radiolucency with a well-defined outline, corticated border, right? Which is associated with apices, periapices of non-vital teeth. And second question, identify the following based on given hints. So follicular cyst, also called as dentigerous cyst, second most common type of cyst in jaws, attaches, this is very, very important, attaches at the level of CEJ, and propensity to displace or resorb adjacent teeth. And also we discussed about expansion of cortical plates, isn't it? Third question, is it dentigerous cyst or KOT? So we might think it is dentigerous cyst, but look at the attachment of the cyst. It's beyond or apical to CEJ. And look at the size, right? So based on some key points, we can differentiate dentigerous cyst from KOT. Also, we mentioned about cortical expansion, right, which is minimal in case of KOT, right? So this is keratocystic odontogenic tumor. Is it KOT or is it OKC? Now that's a debate, right? We had that debate, so I hope it's clear. Now, fourth question, identify the following based on given hints. So the moment you look into this, it's obviously, or it's conclusive that it's lateral periodontal cyst, asymptomatic, less than 1 centimeter in diameter, mimics lateral periodontal abscess if secondarily infected, and it's located mostly in mandible between lateral incisor and second premolar, as we have discussed previously. And finally, identify the following based on given hints. Accounts for 10% of jaw cysts. Incidence is 3 times higher in males found in Nasopalatine foramen or canal. You can clearly see in the radiograph oval, round shaped or heart shaped because of superimposition of nasal spine, and it is associated with vital teeth, which is evident by the fact that the PDL space is normal and you can clearly see entire root outline and PDL space, isn't it? And case-based question. So try to find out the answer and the reason for the same, and we'll discuss some additional information related to this particular question tomorrow or the next session. I'll update you accordingly. Okay, so please brush your teeth at least once a day. Previously I used to say at least twice a day, but at least once a day is an achievement nowadays because you're all busy with preparation, right? Okay, so I'm really thankful to Mother Nature, Mother Earth, science and technology for letting this session happen without much interferences or disturbance. So I hope it's all clear. I hope the session was clear, audible, and the pictures were also very clear, hopefully. You have any further questions, you need any further clarification, you can always get back through mail 24/7, right? So wish you all the best. I love you all. And they seem to be routine words, but I mean it. Okay. Yeah. So how is everything else going on? So what's your plans for Diwali? And yeah, how has been your day? Yeah, you're welcome, Urvi, Vasundhara. You're welcome. Yes, Kavita, definitely. I'll try to incorporate basic subjects as well. Definitely, without any doubt. Yeah, and yes, and an important suggestion from my side, please don't say thank you. In fact, all of our students have this habit of saying WWGOB. So I'll be typing the same. So what is this WWGOB? Right. So you need not say thank you. All you need to say is WWGOB or IWGOB. It's up to you, right? So thank you is not accepted. At the end of the session, only WWGOB is accepted, right? So I hope the session which we conducted in a different way today compared to previous sessions is helpful. Your feedback is always welcome. Your feedback is almost always welcome. Okay. And as I said, for any further queries or assistance, please get back to mail at proudtobedentist@gmail.com. Yeah. So what's WWGOB? So that's a code which I'm sure you will crack by yourself. Okay. Okay, guys. Take care. Good night. Love you all. And I mostly will have a session tomorrow as well. And if at all there are any changes or updates, I'll let you know accordingly. At least 6 to 8 hours prior the scheduled timing, 8:30 p.m. IST, I'll update you with relevant details. Okay. Take care. Give your best.